Hi everybody, this is a short video about documentation, and this is from your Wilkins book, chapter 20. We'll be talking about the general purposes of documentation. We'll talk about what the Joint Commission is, formerly known as JCAHO, and the legal aspects of the medical record, types of medical records, and organizing patient information as well as charting methods. Once a respiratory therapist has completed the bedside patient assessment, consulted other members of the healthcare team, taken notes, and reviewed the information in the medical record, discussed that with the patient and/or their physician, it's time to record all of those findings and plan in the medical record. This process of collecting data involves critical thinking and requires many skills, including communication, analysis, evaluation, explanation, and self-regulation. The difficult part of the assessment is over. However, now you have to describe your findings and thoughts in a concise and readable professional manner. The medical record is a legal document, and so you have to, the respiratory therapist needs to understand some fundamental principles before making an entry into the chart. The Joint Commission, formerly known as JCAHO, is one of the largest accrediting organizations in the world. It encompasses and accredits more than 19,000 healthcare providers and programs in all care settings, and its mission is to continually improve healthcare for the public. JCAHO performs on-site surveys of healthcare organizations to assess quality of the patient care and improve patient safety, and that includes documentation. Good documentation improves communication. General purposes of documentation. Documentation serves as a legal record for the care and services provided. The medical record is more than just a collection of data. You need to understand that it's a legal document. The evidence in this collection supports the patient's problems and needs. And these are clinical facts that we use about the patient's condition for treatment. A correct diagnosis can be confirmed, and the patient's clinical progress can be monitored. It also provides communication among the members of the healthcare team through clinical notes, reports, flow sheets, vital signs, trend values, and test results. And it lets the physician and the respiratory therapist and other members of the patient's healthcare team to document what the patient has received and the quality of that care, and making sure that we stick to hospital policies. Each discipline has unique perspectives that they can bring to the patient's care and to the discussion of the care plan. It also supports appropriate reimbursement by insurance companies, Medicare and Medicaid, and supports the operation of the healthcare organization and its allocation of internal resources like respiratory therapists, physical therapists, and nursing. This type of documentation provides data for legally mandated reports to state and federal government agencies like the Joint Commission. And it can serve as an educational tool. Every healthcare profession has to learn how to use the medical record correctly. It can be intimidating at first, but it's well worth getting used to it. I want to talk a little bit about the Joint Commission and some legal aspects of the medical record. The Joint Commission used to be known as JCAHO, and many of you may know it as that. We now just call it the Joint Commission. It reviews healthcare organizations to improve patient care, and it can revoke a healthcare organization's accreditation. If that happens, Medicare will not make any payments, Medicaid will not make payments to the hospital, and private insurance payments will also not be made. So it's very, very important that we help healthcare organizations that you as a respiratory therapist work for maintain high quality care and record that care. If it isn't documented, it wasn't done. So the Joint Commission looks for documentation of high quality patient care, and the survey team reviews medical records to confirm compliance with that documentation. The following Joint Commission standards from their Medicare and Medicaid accreditation regarding required documentation. Periodically, there are revisions to these standards, but the basic principles of information management and documentation have remained unchanged for many years. This is from the Commission Comprehensive Accreditation Manual for Hospitals, or CAMH. The first one is information privacy and confidentiality must be maintained, and that's a part of HIPAA as well. Information has to be secure, including data integrity has to be maintained, and accurate. The hospital has to effectively manage the collection of health information. The organization also has to maintain complete and accurate medical records for each and every patient. Entries in the medical record are authenticated, and documentation in the patient record is entered in a timely manner. Again, I urge you to chart as you do your treatment or immediately thereafter to try to keep documentation in a timely manner. Again, these are standards for state and federal guidelines and to maintain hospital accreditation. The patient's record contains information that reflects the patient's actual care, treatment, and services. Qualified staff receive and record verbal orders. The organization assesses and reassesses its patients. The organization assesses and reassesses the patient according to his condition at defined timeframes. We especially do this when a patient either improves or declines. The organization plans the patient's care. The organization coordinates the patient's care, treatment, and services based on what the patient needs. I want to talk for a minute about negligence. Negligence is the failure to use a reasonable amount of care, also known as ordinary prudence, that results in injury or damages that require the patient that owed a duty of care to the plaintiff. The defendant breached that duty. The plaintiff suffered a legally recognized injury. The defendant's breach of duty of care caused the plaintiff's injury. You can tell that this is that we're getting lawyers involved here. You need to know that what you chart on the patient's document must be accurate and reflect what you actually did. Anything else is a violation, and you can be fined or even jailed. When someone's trying to, and you're not going to remember if they bring a suit in a year, 3 years, 5 years, 7 years down the road, you won't remember what you did on an exact day. Your charting stands as your record, so you can prove that you did your due diligence, that you did what any other respiratory therapist could be reasonably expected to do. So you did your job, and you did your job well and gave high quality care. That way you will not fall under the term negligence. You do not want to neglect your patients. Negligence is when a clinician or other caregiver has failed to live up to a duty of care owed to another person. Important information about patient assessment must be entered into the medical record in a timely fashion. If a therapeutic or diagnostic intervention is not charted, it is assumed that it wasn't done. Types of medical records. There are different types of entries into the medical record, and these depend on the purpose of that entry. The major types that are most familiar to respiratory therapists are treatment records, flow charts, parameter sheets, and test results. Treatment records are concerned with a single event at a specific time, like giving a small volume nebulizer treatment. The treatment record shows when, how, with what drugs or equipment a treatment was given. The patient's response to the therapeutic intervention must also be included. The record also can contain patient subjective information, like the patient saying, "I feel better," if it's in response to the treatment, and objective information like an improvement in breath sounds that you actually hear. Goals or objectives may also be entered. Written charting. There can be paper charting that we write out on paper during downtime. That's probably the most common time that you'll have written charting. But also we have electronic medical records, or EMRs, or electronic health records as they're more commonly known. Historically, the medical record was a binder or a similar place where you stored at the nurse's station. This is what it was like in the 1980s when I first started as an RT. We had to fight to get the written record from the doctors. We would chart in a binder and then on the appropriate paper documents. However, over the last 20 years, we've converted to electronic medical records. There are advantages to electronic medical records, and these include legibility, increased storage capacity for longer periods of time, accessibility from remote devices and sites, real-time clinical data being input and accessible, built-in alert systems for critical tests and values, customized views for various users, increased management monitoring capabilities, increased accuracy, and a data repository for process improvement and for research. Some of the disadvantages: they're expensive when you first start them up, and then there are maintenance costs to maintain them as well. There's a big learning curve. I was in tears the first time we went to computer charting with our ventilators, because it was so tough to learn and understand, and we had had very little training. That doesn't happen anymore to me. And we're not going to let it happen to you either. There is a confidentiality and security concerns always, and sometimes a lack of standardization, though electronic health records are being more and more standardized. What is a SOAP? We're going to talk about doing a SOAP note. SOAP notes include subjective and objective data, assessment, and a plan. S, subjective. Subjective information is information given by the patient about how they feel and what they can tell you about how they feel. Some of the major questions that this includes is their level of consciousness, their chief complaint, how does the patient feel at the time of assessment? Do they feel good, bad? Can they contribute any information that affects their diagnosis or treatment plan? Objective data is anything you can see or touch. Vital signs, physical examination of the head, neck, abdomen, and extremities for any respiratory abnormality, like fluid in the ankles, puffy ankles. Physical examination of the heart and lungs by inspecting, palpating, percussing, and listening. And review of laboratory results. Review of arterial blood gases, review of pulmonary function tests, any chest x-rays, MRIs, or CT scans, a review of the patient's ECG, ICU hemodynamic data like blood pressure, and a review of respiratory mechanics monitoring like a NIF or MIP or MEP, a negative inspiratory force or vital capacity. Those are typically charted. They're part of respiratory mechanics that we might do for a neurologic patient. Assessment. Assessment forms a problem list. Major types of problems for respiratory therapy include airway management, ventilation, oxygenation, work of breathing, or cardiopulmonary problems, heart and lung problems, like asthma or MI, shortness of breath, or cough. This includes a problem or needs list. Is the data that you found normal or abnormal? This is part of assessment. If the findings are abnormal, are they just a little abnormal, moderately abnormal, or way out of the norm, severely abnormal? Is this a problem, an acute problem, or a problem happening right now? Or is this a problem that the patient's had for a long time, a chronic problem? Does the patient have an acute problem, a problem that just happened, superimposed on top of a chronic problem, like a heart attack and chest pain in a COPD patient? They've had COPD, which is a chronic problem, and now they have chest pain and a possible MI on top of it. Are there any signs and symptoms that are related to each other? And does the data indicate that there is something you can do about the current condition. Here's a typical problem list from your book for the case study 21-2. Let's talk a little bit about the last part of SOAP, the plan. Plans indicate an intervention, something that you're going to do, and a therapeutic objective, your goal for why you're doing small volume nebulizer or asthma education, things like that. A good medical plan includes a goal against which you can measure something. The purpose of the treatment, the responsiveness of the patient, objectives for knowing when to make decisions, objectives as an endpoint criteria for stopping that therapy. When is it considered, the underlying condition considered resolved? All of this should be in the plan. Here's a typical plan or physician orders for the patient in the same case study. Implementation of the plan is when the RT provides treatment at the bedside and you chart that treatment. During implementation, as a respiratory therapist, you need to maintain patient safety and your own safety, be skilled enough to operate your equipment effectively, collect data through assessment before, during, and after what you do, and be observant and record your observations. Evaluation of the results of the plan and implementation. Identify if the problem has been correctly identified and treated, and questions you should answer or think about as you do the treatment. Is there anything here that tells me there were any adverse effects, like an increased heart rate or respiratory rate, increased anxiety on the part of the patient? Was the response what you expected, given your knowledge of the patient and what you did? Did breath sounds improve after giving albuterol, which is what you would expect? Did that happen or did that not happen? Only by listening to the breath sounds and recording all of that can you tell, and can other people in the healthcare team tell. Let's talk a little bit about different charting methods. Most charting methods in use today are based on some variation of a problem-oriented medical record. All of the following charting systems require a clear outline of the patient's problems and corresponding physician orders or professional care plans to address those problems. They can be written in different ways, but they should be profession-specific or multidisciplinary progress notes, depending on what the hospital standards are. The RT typically documents the results of tests and treatments on treatment records, flowcharts, and test records. Failure to do so would call into question whether or not the tests and treatments were actually done. As noted earlier, SOAP charting, SOAP, is one of the most frequently used documentation methods, in part because it is believed to be the best presentation of the patient's conditions and clearly shows how the physician and other team members took care of the patient and how they arrived at their professional conclusions. API charting, or Assessment Plan Implementation Evaluation Charting, has a primary goal of assessment plan implementation and evaluation. This method is to condense all the data collection statements and emphasize evaluation of the effectiveness of the interventions. PIP charting, or problem intervention and plan charting, is at the other extreme from the detailed presentation in a SOAP note. It is a minimalist approach. Problem, implementation, and plan charting is based on the assumption that the data collection has already been done in the medical record and that the subjective and objective information gathering is redundant. Some people dislike this method because they like to see the evidence in a logical order and what the result is. However, the PIP method can work well for experienced clinician who's pressed for time and wants to meet charting requirements and needs to be brief. Under the problem section, the patient's problem is stated simply, often with reference to the evidence that brought the person writing the note to their conclusions. Under the intervention section, it describes what you did. This is often identical with physician orders, standards of care being provided, and the plan shows how the intervention will be assessed, carried out, depending on the intervention.